Hello, welcome. My name is Dr. Jason Prystowsky. This is a recording that hopefully you will all have seen before we have our case discussion on Wednesday, March 9th for your medical ethics class. A little bit about me. I am a practicing emergency physician here in Santa Barbara. I'm board certified. I have a background in public health and providing humanitarian aid in conflict zones. I also work with the 911 EMS system, with our local Santa Barbara Fire Department, with our local public health department, and in a variety of different capacities in emergency services. The title of this talk is Doing Good versus Doing Right. Hopefully this 20 to 30 minute recording that you're watching will all be review. Because you have just had an entire quarter of applied medical ethics. And you can see here, we have Raphael's, the school in Athens, where you have Plato, who's staring up at the forms, talking about theory and the forms and moral theory. And you have Aristotle here with his hand out, looking at the empiric world around us. This is a great image as we talk about applied medical ethics, because it's important for you to have a mind in science, looking at different cases, and have a mind in moral theory, in how to think about normative ethics in a way as to come to resolution of various ethical dilemmas. This is a photograph I took at the Uganda, Congo, Rwanda border back in 2006. It has a story behind it. If you're interested, I can tell you that story. And this here is a photograph of the Broad Street Pump in London, England. You can't talk about medical ethics and distributive justice in the wake of the worst pandemic in 100 years without talking about this international symbol of public health. And maybe I'll give a shout out and kudos to one of you if you Google or Wikipedia the story behind Jon Snow, no relations to Game of Thrones, and the Broad Street Pump. So we're going to jump right into this. This is going to be fast. It is recorded, so you feel free to pause it. And if you don't hear something or hear something incorrectly, listen to it again. We're going to go through this very quickly because this is all review for you. So objectives: why study clinical ethics? Hopefully here at week 10 in the quarter, you already have a good understanding of this. We're going to appreciate how medical ethics in the emergency department is unique. I am an emergency physician. When we look at cases Wednesday morning, all of these cases are very common in our everyday practice environment. This recording is going to talk specifically about the language of clinical ethics. We're going to talk, part of my role as the co-chair of the Santa Barbara Cottage Ethics Committee is to look at ethics cases. And we're going to think about ethical conflict and how to deconstruct different cases to find the point of ethical conflict and where different philosophical theories clash, and hopefully work towards resolution. And then the entire hour and 15 minutes Wednesday morning, we're going to be discussing cases, including some unique cases that have to do with COVID-19. So let's jump right in. For a while, I was involved with the UCSB Medical Humanities Initiative before it was terminated. And I like to show this. This is Ukayu Hokusai. And I know my pronunciation of Japanese is very horrible. So if any of you are Japanese American, I apologize for my crudeness in articulating it. He painted between 1760 and 1849, these block prints. And this is the 36 views of Mount Fuji. And we can spend an entire time just talking about art and how art is an expression of the human condition. But it's important as we talk about ethics that as we look at these cases, we're constantly looking at cases through different lenses and applying different principles and applications of different theories. And here you can see Hokusai has Mount Fuji in every single one of his paintings, sometimes in a reflection behind a tree. It's not always the subject, but it's always in the block print painting. And here you can see these pilgrims on the summit of Mount Fuji. So as we talk about cases, I want to challenge you to constantly look at ethical dilemmas through different lenses and from different perspectives. So why study clinical ethics? John Stone, who is a cardiologist turned poet, in his very famous poem Gaudiamus Igitur, which was the medical school graduation address to the Emory University School of Medicine graduating class of 1987. He said, "For after you learn what to do, how and when to do it, the question will be whether." If you're a fan of Jurassic Park, the movie that came out in the 90s, or the book, everyone was so busy asking if we could, never stopped to think if we should. And then part of being an academic is quoting yourself. In the age of technology, can always precedes ought. And by the time ought not is determined, it may be too late and cannot be reversed. Most of the cases we look at are cases unique to the emergency department. When I attended UCSB in the 90s, this was the show that we watched every Thursday night, ER, executive producer by Michael Crichton, with starring George Clooney. The emergency department is a very unique place. And I know some of you are work in the ER, either as scribes or EMTs or patient care techs. Medical ethics in emergency medicine is actually incredibly unique because rapid decisions are constantly being made with incomplete information concerning patients who often lack capacity for decision-making and are often there unable to participate in their care. There's no prior relationship with the patient. We're meeting them for the first time there. A lot of patients arrive in crisis, and sometimes they're brought against their will. An ambulance brought them and they never actually wanted to come in the first place. Many of our rapid decisions with incomplete information have irreversible outcomes, and it's within a hospital setting where we work very closely with multiple pre-hospital personnel, technicians, allied health personnel, nurses, social workers, paramedics, mental health providers who all look at healthcare differently. So it's an environment that is very ripe for ethical issues. So what is ethics? Hopefully you've all discussed this. Ethics describes moral values attributed to the conduct of a person or group and can refer to the moral status of a person or enterprise. By the way, all of these lecture slides you have. So they should have been posted on Gaucho Space. So you can follow along. None of this you're going to be tested on. This is just for your value. Normative ethics is what we tend to use in the realm of medical ethics, which is a very pragmatic, practical tool that refers to, in different acts, what is the right thing to do. This is right, this is wrong. Metaethics is far more abstract, and if you are a philosophy major, you may have taken a class in metaethics about what is it about good that is actually good. Virtue ethics, which now in my career I have a very big interest in, has more to do with character, and it's Aristotelian. Mackey is a contemporary virtue ethicist that looks at when you're looking at an ethical deed or an ethical act, you look at the person who's doing it. And because your professor is a very moral man, then whatever he does is moral and ethical. I like looking at character now, and I've been reading a lot of Stoic philosophy, looking at character. And if any of you have any questions about it, we can certainly get you pointed towards the right direction. Descriptive ethics is like anthropology. It's used by social scientists that, in certain communities, an act is wrong because that's how it is in the community. For instance, in India, it's wrong to kill a cow. But that's not the case if you're in Texas. So, it has to do a little bit more looking at the anthropology and the measurements of different behaviors in that particular population of people. So I like to think about normative ethics summarized in two questions, right? What ought you do and why ought you do it? For those of you who are interested in a career a very rewarding career in healthcare, you're going to have ethical dilemmas your entire career. And it's important for you to be able to recognize when an ethical dilemma is occurring, when a conflict is occurring, and use the tools in your tool belt to deconstruct it and find out exactly what is it about this that makes you feel uneasy, and then use the tools in your tool belt towards resolution, towards an ethical outcome. Now, when I give talks about medical ethics to other physicians or medical students, it always gets back to the law. So You know, when we talk about our cases, we're going to be talking about ethical principles, not the law. But you have to mention the law because a lot of physicians, they like to think, oh, what am I going to do that I'm not going to get sued for? Or I'm not going to be brought up on criminal charges. And though the law is not central to this talk, it really can't be ignored. And I like Alex Morgan Capone is a emergency medicine ethicist. And he said the law frames decisions making in emergency medicine, but ethical analysis provides the details of the picture. Like, it's important to include the law, but there's a lot of times where you will lose sleep because you felt you acted in an unethical way that was not in the best interest of the patient. But what you did was totally legal, especially now in these times of crisis standards of care, as we've seen with the pandemic, where a lot of times with emergency declarations, the law changes. But still, we want to hold ourselves to the highest standards of ethical behavior. The relationship between morality and jurisprudence is really out of the scope of this. If any of you are pre-law, we can certainly discuss it. So as we talk about cases, I don't want you to think about cases as what can I get away with or what will I get sued for, but what is the right thing to do and what will bring about the greatest good. This was, when I was at UCSB as a philosophy major, this was a very influential book for me, written by Thomas Sowell, who's a political philosopher. And he wrote this book, A Conflict of Visions, and it just blew my mind when I read it, because he talks about how all political conflicts are rooted in an underlying conflict of philosophical ideology. And when you recognize where those philosophies clash, that is the first step to resolving the political conflict, as he talked about in his book. And this is especially important as we talk about the crisis in Ukraine, which is happening right now. When I was a resident in Atlanta, I was on the ethics committee at Emory University Hospital and Grady Memorial Hospital with my mentor, Dr. Bill Sexton, who is a neonatologist and very wise academic who would always ask questions until he got to what he called the point of ethical tension, a point of ethical conflict. This is what we're really talking about. It oftentimes is a misunderstanding or miscommunication, or simply a different in prioritization of different principles. Classic example is abortion is about whether or not the fetus is a human being. And at what point does that fetus become a human being? That's what that's where the point of ethical conflict really arises from. And once you start recognizing that, then you begin to create steps towards greater understanding. So language of ethics. Here we go. Deontological ethics. We're going to talk about beneficence, non-maleficence, autonomy, and justice. And here you can see Keanu Reeves back in Bill and Ted's Excellent Adventure, a movie from the early 1990s with Socrates here. And all of this should be reviewed, hopefully talking about the deontological principle of always do good, salus agroti suprema lex, right? The practitioner, the physician, the nurse, the healthcare provider should always act in the best interest of the patient. It creates an obligation to act. It's a deontological ideal. And we're going to talk about deontology in just a little bit. Non-maleficence, right? Do no harm. Primum non nocere, right? You have a duty not to act when that act will cause harm or when inaction will result in harm. And this is the first thing they teach you in medical school. Like when you become a resident in the hospitals, if you watch the TV show Scrubs or Grey's Anatomy, they always say, whatever you do, don't hurt anyone, right? Don't cause harm. Non-maleficence. Autonomy. This is a very American ideal. This is the notion that people ought to determine and make their own choices regarding their life, right? This is like Kant's principle that people should always be an end and not a means to an end. That the person is the captain of their fate and determines the outcome of their narrative. If you go and practice medicine in other places in the world, there's a much less emphasis on autonomy, which we put here in the United States, and much more on paternalism. We'll talk about paternalism in a little bit. Justice. is an idea involving the moral and fair treatment of all people. It's very important when we talk about distributive justice, right? Making sure that the allocation of scarce resources and the decision of who gets what treatment is fair and just. Or as Aristotle says, giving to each that which is their due. My favorite moral philosopher when it comes to justice is a contemporary Harvard philosopher who died in the 1980s, John Rawls. If you want to read on justice, it really another book that I quote many, many times. And this can be consequentialist or deontologic, but justice has become a very important notion where when the pandemic hit and we were determining who's going to get a ventilator and who's not, if we run out of ventilators, who's going to pay for our healthcare system when we run out of money, when some people don't have access to healthcare, or when we're talking about a disaster and we only have so many operating rooms, who's going to get that resource? We want to use principles of justice to determine that. This is one of my favorite 1990s cartoons. I'll let you read it if you want to. Some other principles is important that a lot of times they don't keep in, they're not necessarily in the philosophy textbooks, but when you become a practicing clinician, is very important to your career is respect. You refer, you make sure that you've done your due diligence to understand the values of the person and the people you're working with, and that you respect their dignity. A lot of times, ethical conflict comes down to patients or patients' family members not feeling respected, and that's why the ethics committee gets consulted. Truthfulness is very important, especially when medical errors take place, right? Is not to lie to your patient. They deserve to know the truth about their health, their illness, and their care. And then futility is when the action or expenditure of resources is incapable of producing any kind of valuable outcome. There's been a shift in applied clinical ethics away from the language of futility towards medically ineffective care, because when people hear futile, it has a lot of negative connotations. But when we start talking about, okay, if grandma is on the ventilator and we really continue to escalate her care aggressively with a lot of procedures when there's no possible way she'll survive, that's medically ineffective care, and we need to think about the consequences and the moral implications of doing that. Hopefully, you've talked about capacity. Capacity for decision making in the world of the law is someone's ability to enter into a contract. They have to understand the risks, benefits, and consequences of their decisions. As you can argue, this baboon does not necessarily understand that awakening a sleeping lion is unwise. And when we talk about capacity for decision making, this happens all the time in the ER. When we have patients that come to the emergency department that may be intoxicated with alcohol or recreational drugs, patients that may have been hit in the head and have a head injury and are not in their right mind, young children, the elderly who may have dementia, they may not have the ability to understand the options and understand the relevant consequences of various decisions. They may not be able to evaluate the costs and benefits. And especially when patients are brought to the ER by law enforcement, there may be a component of coercion. And it's important that all of these are necessary for informed consent. Yep. So informed consent, when I'm going to take someone to the operating room, the patient has to have capacity for decision making. I, as the physician, have to disclose what would be a reasonable person standard as far as the risks and benefits of the procedure. The patient has to have to demonstrate understanding that they've comprehended the risks, consequences, and benefits, and they have to be voluntary, which is very important now in our healthcare system, where the number one cause of homelessness and bankruptcy is being ill. Right? So it's important to think about, sometimes people may be refusing care and doing so out of financial coercion. Paternalism, you can see here, this is a photograph of the cover of Thomas Hobbes' book, Leviathan. He argued for the monarchy because as a paternalistic state. Paternalism is when we make decisions for other people. This is the opposite of autonomy, and sometimes it's done in other cultures. If you practice in other places in the world, it certainly is the model we practice when the patient does not have capacity and there's an emergency, and we use emergency implied consent because the patient right now is unconscious and they cannot tell me what their values are. They can't tell me that they're a Jehovah's Witness and don't want a blood transfusion. So I'm gonna practice in a paternalistic way and practice the implied best model of care based on the best available standards. So when capacity is lacking, when a patient doesn't have capacity for decision making, sometimes we'll use a durable power of attorney for healthcare. This is a person who has been appointed as a surrogate decision maker, who can legally speak on behalf of the patient. Very common in the elderly, common in those who have irreversible cognitive or neurologic disorders. Some patients may have a living will, which is a document that's going to specify what they want should their capacity be lacking. And when there's no durable power of attorney or no document, we use a surrogate decision maker, which is going to vary state by state, but we're going to go ahead and try to find a surrogate decision maker who is going to be in the best position to speak on behalf of the values of the patient. Oftentimes a spouse, maybe a parent, maybe an adult child, siblings. I put in here same-sex marriages because, as of recently, same-sex marriages are the law of the land. But when I trained in emergency medicine in Atlanta, Georgia, they were not. And oftentimes when a patient had end-stage AIDS, their partner of 30 years was not allowed to be at the bedside because, according to Georgia law, the next in line to be the surrogate decision maker was the adult parent who may or may not have had a very good relationship with the patient at that time. And so it's always very important to know what your goals of care are and who should make those decisions. When I teach medical ethics, I used to always send my students home over Thanksgiving and over the holidays and say, when you go around the Thanksgiving table, talk to your relatives about what you want should you have a terminal brain injury and would be in a persistent vegetative state. Because the people sitting around the Thanksgiving table are going to be the ones who are making those decisions for you. So if you have very strong opinions, make sure that your family knows them, or you put it in a living will, or you appoint a durable healthcare power of attorney. Hopefully you've talked about some of these cases. Nancy Cruz, Karen Quinlan. This is Terry Schiavo. This is her when she sustained her hypoxic dysrhythmic event from low potassium. This was her a few months before she died. This was her CT scan initially. You can see all the brain matter. This was her CT scan just prior to her death. Very famous case in medical ethics that we're all following that a lot of us have followed very closely because her husband had wanted comfort measures, and then her parents, who were faith-based, advocated very hard for her to remain on a feeding tube against her husband's wishes, so much so that the governor, Jeb Bush of Florida at the time, did an executive order, Terry Schiavo's law, to reinsert the feeding tube. So oftentimes politics does get into medical ethics. So it's important for you to know these different principles and have a strong foundation in them. In the state of California, we use a PULSE form, which is this pink form. It's a physician order for life-sustaining treatment that in a very succinct way says if someone is do not resuscitate or full code, if they are full treatment versus selective treatment versus comfort care, and whether or not they want to be supported with artificial nutrition. And this is a legal binding document in the state of California that if you're admitted to the hospital, a lot of times a case manager will help you fill this out should anything unexpected occur to make sure that whatever happens is consistent with your values. Rights theory. Here's Thomas Jefferson and John Stuart Mills. Hopefully you've talked a little bit about negative rights and positive rights. Negative right, a person has a right to not be interfered with so long as this right does not interfere with the rights of others, meaning I can wave my arms as much as I want as long as I want. But once my hand hits someone else, then I violated their right. So I have the right to wave my arms as much as I want. No one can mess with me. I am I have autonomy. A positive right is has a projected entitlement. This basically says that, when someone comes to my emergency room and I'm the physician, it's their right for me to treat them. If you are drowning at the beach, then you have the right for the lifeguard to jump in and save you. That's your right. In some cultures, if you stumble onto a car crash, it's the victims of the car crash right that you stop and help them. Do people have a right to health care? We're talking about positive rights. And it's important to just understand this language as we engage in the discussion of these cases. So we've mentioned consequentialism and deontology. Consequentialism is founded in the philosophy of utilitarianism from John Stuart Mills and Jeremy Bentham, and it's focusing on good outcomes. This is what we use in triage when we think about the triage systems we use in emergency medicine and 911. We want to bring about the best possible outcome for the most people, or in the needs. If you're a Trekkie, the needs of the many outweigh the needs of the few. But sometimes when you apply a non-rule-based utilitarianism or consequentialism, it can allow unethical acts so long as the outcome is good, meaning the ends justify the means. So when we think about, especially now in the shadow of COVID, disaster medicine, it's a lot of times our principles in disaster care are very consequentialist. How can we do the most with the limited resources we have? This is Robert McNamara, Secretary of Defense under Kennedy in the Vietnam War. He said, in order to do good, sometimes you must engage in evil. So consequentialism. Deontology, on the other side, doesn't look at the outcome at all. It looks at the act. Right? Deon is a Latin root for duty. It focuses on doing the right thing, irregardless of the outcome. You may or may not have been exposed to Immanuel Kant's categorical imperative or the Bible. We talked about the principles of beneficence, non-maleficence. Doesn't matter the outcome. It doesn't matter if the person who showed up in your ER is a Nazi or is a fascist or is a terrorist. You help them, you take care of them because of beneficence, non-maleficence. They're your patient. It's you have to take care of them, regardless of the fact that once you cure them, they're going to go off and do horrible things, and the world may be a better place without them. But that's not your decision to make. Sometimes doing the right thing can result in bad outcomes. If you ever read the Hippocratic Oath, it's a very deontological document. Most of it actually refers to how you should behave on a house call when being invited in someone's home. So when we talk about ethical conflict, a lot of times it comes down to consequentialism versus deontology, right? When we're talking about, giving ventilators to people during COVID and we run out of ventilators, consequentialism will say you have to give ventilators to the people who are most likely to benefit from it. Whereas deontology say they show up at your hospital, you give them a ventilator. And once you run out of ventilators, you turn people away, all right? You just do the right thing. A lot of times the point of ethical conflict in a case comes down to deontology versus consequentialism, right? Doing good, best outcome, versus doing right, best action, hence the title of this lecture. A lot of times it comes down to autonomy versus paternalism, classic conflict in the ER. A patient wants this. I think the patient needs that. The patient comes in, they say, I want ivermectin for my COVID. I say, well, ivermectin doesn't work for COVID. We're going to use monoclonal antibodies. I am not recognizing their autonomy. And either I can exert my paternalism and give the appropriate care for the patient's condition, or, but a lot of times the conflict, the point of ethical conflict is an issue of autonomy versus paternalism. And as we go through cases, we're going to see these two principles in active conflict. A lot of times I like to use what's called shared decision-making, which is I always respect the autonomy of my patient. And I tell them, look, I'm the doctor. This is what I think you need. Tell me what you think you need and why you need it. Let's have a discussion, and we'll have a shared decision-making outcome as far as what to do. I'm going to skip over the doctrine of double effect. A lot of times this is used in the setting of abortion when discussing this. This is Judith Jarvis Thompson, very famous ethicist. It can be important when we talk about side effects and complications from procedures. Meaning sometimes someone comes to the ER and they have a gunshot wound to the chest, and I'm going to do a thoracotomy. I'm going to make an incision, open up the ribs so that I can go in and repair. And sometimes that procedure is ultimately what causes the death of the patient. My intention was not the death of the patient. My intention was to stop the bleeding and save the life. And the death was a foreseen but unintended consequence. You may have talked about this in prior lectures for your class. And at this, I'm going to stop with this recording, because when we show up to class on Wednesday, we're going to talk about the cases. You should have the PowerPoint. Please feel free to review the cases ahead of time. I don't give any of the answers. But it should be a fun class to discuss. I'm looking forward to meeting all of you, and everyone should get a good night's sleep and make good choices in life. And at that, we are going to stop this recording.